All right, welcome to Eating Disorders in Midlife. My name is Danny Gillity, the Executive Director at the Eating Disorder Foundation, and I am delighted to welcome everyone here tonight. Today's workshop is brought to you in collaboration with the Eating Disorder Foundation and Within Health. If you have questions for our presenters this evening, I invite you to use the chat feature to submit them. Please be sure to indicate which presenter your question is for so we can get it to the right person. We will save time for Q&A after the presentation, and I will deliver the questions to our panel. We will do our best to get to everyone's questions, but since we'll have limited time, we will follow up with an email answering questions we don't get to. The chat will be left open, so we ask that you all remain respectful and understand that we have the right to remove anyone we feel is being inappropriate. A few words about the sponsoring organizations. The Eating Disorder Foundation was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver-based nonprofit that is now serving individuals and families both nationally and internationally. Please remember or check out that we have a support group for individuals 50 and over that meets on Tuesdays from 4 to 5 Mountain Time. It's an incredible space, so I encourage you to join if you are able. And you'll be able to find more about both our organizations. I'll put the websites in the chat feature. But now I want to hand it over to Erin, who will share a few words about Within and will also introduce our speakers.
Yes, thank you, Danny. Thank you so much for having us here. We are so excited. I really quickly want to talk a little bit about Within Health. I do the business development, and a big reason of why Within was created, we wanted to really not only provide greater access to care, but to provide high quality treatment through an accredited treatment program for anybody, anywhere. So we are intentionally virtual, and we've created an app that the whole program is run out of. So we do both PHP and IOP for adolescents and adults. This is one of my favorite slides to show. It discusses kind of what makes us unique in the sense of we're a highly structured, clinically rich program, but we don't have the rigidity. So we have a lot of flexibility to meet each patient where they're at, both clinically and dietarily. This is the robust treatment team that all of our patients do have. A unique aspect is we also aren't staff dependent. So we have these awesome specialists that have joined our team. And this is a little snapshot of what our app looks like. Because we're intentionally virtual, there's a lot of thoughtful aspects to it. So we're able to enter a patient's home. We're able to be really what we call intrusively loving. So being with our patients in the moment that really, really matters the most. We get to do a lot of exposures and be a very interactive program. And again, this is my information, my contact. If you have any questions, please reach out. These are the states that we are in. So feel free, my email and my cell phone, happy to provide some more information. And without further ado, I would love to introduce our presenters today. We have Dr. Wendy Oliver Pyatt, who is a world-leading expert in treating eating disorders. With more than 25 years of clinical experience, she has developed 4 separate treatment programs, all grounded on a strong biopsychosocial foundation and incorporating intensive psychotherapy with behavioral foundations and high medical standards. She's a fellow of the Academy for Eating Disorders and the International Association of Eating Disorder Professionals. She has received senatorial recognition for her commitment to the mental health treatment community. Next up, we have Dr. Leslie Williams, who is a family medicine physician and eating disorder expert. She received her Doctor of Medicine degree from the University of Kentucky College of Medicine and completed her family medicine residency training at Mayo Clinic, Arizona. Dr. Williams has been providing medical care for patients with eating disorders and other mental health issues for over 17 years. Lastly, Ibbets Newhall joined the eating disorder field in 2006 as an outreach professional, and for the last 5 years has been an expert in eating disorder treatment planning, helping patients and families navigate the full arc of treatment from pre-admission through aftercare. She was a founding member and secretary of IADEP New York and served the advisory board for Center for the Study of Anorexia and Bulimia and Binge Eating Disorder Association. So without further ado, I will hand it off to the presenters.
Thanks for that great welcome. And I have the pleasure of being your first presenter for this evening. So it's so great to see so many people on this call. I'm just delighted to be here and have this conversation. And I can just recall when I first started talking about eating disorders in midlife, it was definitely a novel topic and something that people just didn't recognize. And I'm just so excited to see so many people here today and just excited about this conversation. So next slide. In general, as was stated, I'm a family medicine physician, and I tend to be on the front lines when people have questions about what's going on with my body. I mean, oftentimes these are adults who are used to their body kind of operating in a certain way. And when things begin to operate differently, they get very distraught. And they typically come into their family medicine physician and say, what's going on? Why am I not looking like these girls on TikTok or Instagram? And why are things happening in a way that I don't see portrayed out there in the media? And I'll just start off by saying culturally, we do not normalize the physiological changes associated with aging. Instead, we have a society that is just obsessed with the idea of maintaining youth. And oftentimes that pursuit of maintaining youth is something that can just become all encompassing. And so frequently my conversations are about, what does normal maturing or aging look like? And what are some things to expect as our bodies mature? And how do we determine kind of what's within the norm versus what's something that I should be worried about? Next slide, please. So eating disorders in midlife. Midlife is especially vulnerable for men as well as for women. As I mentioned, the body is changing. So similar to what happens in puberty, we have this way that we're used to kind of being in community with our bodies. And then all of a sudden things are changing and we have no control. And I'm sure many of you have heard time and time again, eating disorders can frequently be born out of that feeling of a lack of control. And if I can control what I eat, if I can control how I move my body, if I can control my body, then maybe I can stop these things that are happening around me that I have no control over. And oftentimes we'll see the beginning of an eating disorder at midlife be about this premise of getting healthy, this idea that, hey, my body's changing. And so that must mean that it's time for me to get healthy. So I'm going to, instead of working out 30 minutes a day, I'm going to start working out multiple hours a day. I have this new access to time and resources, and I'm just going to pour that all into trying to control this natural process that's happening with my body. And so oftentimes it's just not only a time for women and men to be vulnerable to the development of an eating disorder, but oftentimes if maybe they struggled as a teen and have gone through a period of remission, this is also a time where they may be vulnerable to relapse. Next slide, please. So the next several slides, we're just going to talk a little bit about the biology, about all of these changes that tend to coalesce around midlife and can kind of stir up this idea of what is happening to me. Hair is a huge thing. Oftentimes it's a kind of like an extra accessory that we have with our bodies. We're used to our hair operating in a certain way, and all of a sudden we hit midlife and there's hair loss or thinning that takes place for men as well as for women. There's changes in the texture, there's changes in the color, this graying, this all of a sudden having this big outward display that I'm maturing. And what I like to refer to as like hair relocation, people coming in stating that they have hairs in places that they're not accustomed to them being. And so that can be somewhat distressing as well. And then we see issues in terms of like, sometimes we have a little bit of slowing of our processing speeds, maybe some issues with memory. Skin changes are another big thing that we start seeing around midlife. Maybe the skin becomes more dry, some thinning, some decrease of the elasticity. So again, starting to see some of these outward changes, even when we feel well inwardly, that can start to cause some distress about what's happening. And then also, as I mentioned previously, we might have people that are like, I'm going to go and train for a marathon, and then all of a sudden the joints are maybe a little bit more vulnerable to injury, some difficulties with overuse. And so we really have to be somewhat careful and mindful of this idea of like, hey, I'm hitting whatever that midlife marker is, and I'm going to get healthy and all of a sudden make all of these kind of drastic changes. Next slide, please. The other thing that happens in terms of the body is that there can be a shift in terms of weight, and not even just a change in terms of an increase in weight, but a change in terms of weight distribution. So I'll hear from men and women that they're noticing a little bit more distribution around the middle section, that maybe the muscle tone has decreased, just a general change in kind of how they're used to their body looking and being. Decreased muscle mass, as I mentioned. Also with women, we have menstrual irregularities, changes in libido, and sometimes their partner maybe isn't in sync with those changes in libido. So one partner may have an increase, another one may have a decrease. Men have difficulty sometimes with erectile dysfunction. So all of these changes that are starting to just coalesce into this idea of I'm just feeling uncomfortable in my skin. GI issues are another big thing that can become distressing. Oftentimes we can go our whole lives without ever really thinking about our GI tract. I remember thinking about like my grandmother, why is she so obsessed with like going to the bathroom? But as we age and mature, it becomes more of a thing that we're concerned about in terms of what we eat and then how our body is impacted. And so again, this idea of I have to be, much more mindful about the things that I can eat because my body just responds differently than it did at an earlier stage. Next slide, please. Some other things that we'll see too are changes in terms of sleep pattern, which can definitely impact mood. I also have patients that present for the first time with new onset anxiety, oftentimes depression. And the depression can have to do with just this idea of hitting this certain milestone, changes in terms of roles, which is going to be talked about a little bit later by Ibbotts. And so we can see some of these mood things that start to crop up that maybe we didn't see previously. Irritability, which can sometimes be associated with hormonal fluctuations. And so all of this comes together with this idea of this body that I had that was operating perfectly fine, all of a sudden, against my will, is going through all of these changes, and I'm feeling just completely unnerved by this, male and female. And so that's what really creates that vulnerability, this idea of I have to stop this process. When I look on Instagram, when I look on TikTok, all I see are these people that are claiming to be 60 but look like they're 30, and that's the expectation out there in the culture. And so what can I do to kind of maintain that? And so a lot of times I just come aligned with patients and kind of talk about, hey, these are some of the things that naturally occur, and we want to recognize that and figure out what things that we can do to kind of help along with the process. But our life's work is not stopping the clock, right? Our life's work is to kind of embrace and just be along for the journey. Next slide, please. So some of the things that we can do to help embrace healthy aging is balanced meals, working on that idea of trying to incorporate a variety of different foods, physical activity, maintaining that muscle strength. I really cannot stress enough stretching. That's one thing that's definitely overlooked, is this maintenance of joints and balance. I often talk about weight maintenance with patients. I tend to be a weight neutral provider. I don't talk a lot about weight, but just even bring up this idea of your whole purpose is not to lose weight, but this idea of, just staying where you're at and kind of learning how to work with your body where you're at can be somewhat uplifting for patients who have spent their whole life kind of with that goal of weight loss. Getting adequate sleep is super duper important because we know how sleep disturbance can impact. Limiting alcohol intake. And one of the biggest things is maintaining social connection, knowing that you're not alone, that there's other people out there that are going through those same changes, and kind of maintaining that social interaction can be so positively impactful in terms of our overall health as we mature. And next slide, please. So in general, the takeaways I want to leave you with today is that aging is natural. We really need to work harder on normalizing it. Bodies change in midlife, and we want to work to accept it. And eating disorders can occur at any time, and we want to learn to recognize that. And I have just one quick quote. People say, and this is from the Huffington Post from just in April, writer Melanie Brooks. And she says, people say turning 50 is fabulous. Here's what they didn't tell me. I'm scared. I'm scared that I'm 50 and I haven't done enough. And I'm scared that I'm 50 and I don't know what to do now. And I'm scared that before I can unravel these fears and grab onto a tangible thread of direction, time is going to run out. Positive thinking and sometimes my therapists tell me to wrap my arms around my fears and pull them close and listen to their wise whispers. On the other hand, my body is telling me to just grab a handful of chocolate chips and hide under my weighted blanket. But the immediate challenge is that since there's only so much fulfillment I can garner from the chocolate chips, maybe I don't have to go as far as fully embracing the things that scare me, but I can at least acknowledge them, give them a little space inside of all of this new wide open space I have, and stop trying to run from them. So that's kind of the message, is that we're embracing this idea of aging, and we're going to talk about that and how we can help come alongside those that are struggling with eating disorders in the midst of it. Thank you.
Thanks so much, Leslie. That was awesome. I don't know that you could see me wildly nodding. Fabulous. Hi, I'm Ibbotts Newhall, everyone, and it's so nice to be here. Thank you so much for asking us all to be part of this. This is a conversation I feel like I've been having for quite a while. And it's, as Leslie began to reference, age does not discriminate in the prevalence of eating disorders. I mean, pre-pandemic data indicates that, when it comes to the increasing incidence of eating disorders and body issues, 13% of adult women are struggling with eating disorder symptoms. This is a stunning number. And for context, if we think of all the focus that sometimes is placed on some of these other diseases and the amount of money and research and insight, when we look at the fact that breast cancer affects 12% of adult women, but receives so much more focus and attention. And if we just think about that for a minute and think about the ways in which our feelings about our bodies and the things that Leslie's spoken about permeate our lives, we need a little bit of a reframe, not just for this age, but for every age. Erin, could you move on to the next slide? As a woman of a certain age, shall we just say, in conversation with so many of my friends and professional colleagues, the intense fears that Leslie began to describe, the people that come into her office, that fear of what's next. Yes, I'm supposed to embrace that I'm 50. I'm supposed to do all these things, but I'm still frightened. And so often that fear often translates into a desire to have that control, to turn back the clock, to trick our bodies into believing that time is not marching on. Next slide, Erin. And what is being looked in all of this, is if we take a look at the data, it's really quite shocking. These studies are from prior to 2015 and pre-pandemic of US studies of women over 50. And all of us, and those of you in the audience who are doing the amazing work of working with those that suffer from eating disorders at any age, and for those of you that are working with those that are in middle age and beyond, you're seeing this every day. You're seeing the uptick and the tsunami of need that has been increased by the pandemic. But this is some of the data that we have from about 2015. As I mentioned, more than 13% of women over 50 report eating disorder symptoms. 79% report weight shape affects their self-image. I mean, I think those of us in our casual lives can hear these conversations over and over in our heads. So many report that their concerns about weight and shape, as Leslie referenced, they're looking at the TikTok videos of the 60-year-olds who look super fabulous. And why can't I do that? 41% report weighing themselves daily. 36% report spending at least half of the last 5 years dieting. 8% report purging. And then when we look at this statistic of women aged 61 to 92, what bothers people most is weight and body. And this to me is heartbreaking at this moment in our lives where we have and should have so much to celebrate. This is a thing that guides our thoughts day in and day out. Next slide, Erin. And what happens? What causes this? As Leslie's begun to reference, it's that perfect storm of life events and feeling like you don't matter anymore, that you are somehow replaceable. Leslie has talked about, and Wendy will talk about menopause and those other natural signs of aging. Sometimes our relationships change, that where our relationships with friends, with partners, and this is incredibly unsettling. These numbers that I referenced before are really quite stunning. And, we have to understand that the presence of eating disorders in mature women and the roadblocks that these adults have in receiving appropriate attuned care. This really became apparent to me when I first joined the profession in 2006. And I would say that this is both personal and professional because it spurred so many conversations. In fact, Wendy and I actually had a conversation, I think in 2011 when I joined Oliver Pyatt Centers, about meeting the unique needs of this population. What are the circumstances prompting often the reemergence in middle age of the eating disorder, and how in treating, and I'm referring to women, and thank you, Leslie, for referencing males with eating disorders at this age too, which is a very misunderstood population. How can we honor both their unique gifts and address the challenges? No one really talks about it, not medical professionals or families. And I think it's really important for us to think about how in all these things that are going on that we're going to be talking about this evening, how that empty nest, children are moving out of the home. What does that mean for a caregiver? The work environment may have shifted. A lot of individuals find themselves competing with younger workers. What does that feel like, to feel like you are somehow no longer relevant? Even something as exciting as retirement and other life changes can be incredibly unsettling, and the health issues that Leslie has referenced. Next slide, Erin. So how do we respond to these changes when 50 is supposed to be the new 30? Well, of course, we go to town. We do all the extraordinary things that Leslie brought up. And for that, and the unfortunate thing is we so often get the positive feedback for those changes from family and coworkers and friends. Oh, you look so great. What are you doing? What is your secret? Keep up the good work. And for that individual who may have slipped back into an eating disorder, often when asking for help, they may get a response that I don't know how else to say this, but is completely blind to what's going on. We often see that individuals not only, are professionals not connecting the dots. They often speak about the good work that an individual is doing, as well as what the friends may be saying. So they may get a response from a medical professional who's not as attuned as Leslie or Wendy, that can say, gosh, how do you feel about your new body, when they may be experiencing rather extreme behaviors and are looking to that medical professional for that help and guidance. Next slide, Erin. So as as these individuals are seeking treatment, what is some of what gets in the way? Because we want to really talk about how we can meet the needs of these individuals. And for those who have cycled in and out of eating disorder behaviors, probably for decades, there is a tremendous amount of shame. They think, I'm just too old to have this still. How is this happening? Or they may have the narrative, I'm not as bad as I was when I was younger. For those who are first-time onset individuals, that stumbling block can be somewhat different. They may not be connecting the dots between their behaviors and the disease. They are feeling, because they may be getting all that positive reinforcement, they're feeling successful. Or as Wendy said when we were first talking about this, she said, did you say successful or successful? I wish I'd come up with that myself. I thought it was so brilliant, because really, I think that so sums up what is often happening with these individuals over time. They are successful and they're getting tremendous amount of reinforcement for the behaviors actually that are pulling them into the dark and the deepness of the eating disorder. For many women, and I saw this when I started working in the eating disorder field, I came into the field as a woman already in her 50s. So this was something that I cared about deeply. It was both a personal and professional interest. And so I understood and see then, as I see today, that often those responsibilities at home and work have a tremendous pull. There may be financial concerns. There may be shame that I don't deserve to go to treatment at this age. I don't deserve to reach out and get the support I need. Often because there may be retirement concerns, there may be kids they have in college, there may be other family members who have illnesses. So often this is a factor that we don't always recognize that may be preventing them from seeking treatment for themselves. And feeling othered in treatment. I think for many, the thought of going into, whether it's a higher level of care, whether that is a PHP, IOP, or residential level of care, there's a feeling that no one is going to really understand who they are. These are also individuals for whom the scaffolding of the eating disorder has been with them perhaps for decades. And it is terrifying to think of losing this thing that has so helped them in many instances and defined them. And it's the thing that the families around them often think, well, that's just who mom is. That's just who my sister is. And the families sometimes are not always recognizing the need for that individual to get into care. Next slide, please. So at this moment, I'm gonna pop away from this slide just a little bit and return to it. I think I've had so many great teachers along the way, Wendy being one of them. But I think back to a conversation that I had with my friend and colleague, Susan Kane, who's a little older than I am. And she and I also convened a group of professionals, also women who are a little bit more senior in the field. And she referenced how personally and professionally that you can suddenly feel, as I said before, that you feel obsolete and invisible. You become a shape. You're no longer this vibrant, contributing person. And as Leslie had pointed out, all of a sudden you don't know where you stand. It's like being in puberty. At 10, you know exactly who you are, but at 13, it can get really, really confusing. So I also did a panel and began a conversation with the wonderful Margot Main, Karen Samuels, and Mary Angelo, based on an article that they had written for a scholarly document back in 2015. And it is, I really loved what they had to say about working with women at this point, that really making sure that we are addressing the gifts that these individuals have at this age, the learned experience, the insight that they may have. Sometimes one of their fears about coming into treatment is all that they've accomplished, all that they have become is somehow going to be ignored. And, when Wendy and I first began our conversation back in 2011 was, how do we address those strengths while addressing the severity of the disease that may have been with them for decades? I think of one of the first clients I had when I began my consulting practice, who was 61, and she got her first treatment at that age because her brother and sister intervened. And I think of what it gave her that was so extraordinary. And I think of all the conversations that I've had, even just yesterday and today, one with a woman who I was speaking to who finds herself stuck in her 50s and is seeking answers and wants to know why this is happening at this point in her life, why she can't control it. Or the mom of a woman in her 50s, how do we address this with her? How do we get her into treatment? And I think it is important to really think about what eating disorders can sometimes give us at any age. And at this age, the scaffolding that it can provide. As Mary and Margot and Karen wrote, in their article, that perhaps the line that stuck with me the most, that what a paradox it was that at this moment of time, the thing that, as they're looking at their lives and trying to deal with everything around them, what they grab a hold of, and I'm paraphrasing here, is what can be a life-threatening disease. It's really important to recognize how we are hardwired and the importance of that, and to embrace, as Leslie said, who we are and being proud of it. In speaking of women, we are built for survival. We have been programmed to prevail over millennia. Adult women typically have 22% body fat, and that is meant to give us enough energy as an ovulating female to survive famine. Think about that. 9 months. Why? And that transition to menopause, which increases estrogen by producing those fat cells to maintain bone density, to help provide us those special, survival, what's the word I'm looking for, that way to decrease osteoporosis risk and manage menopause symptoms. We know that moderate weight gain at midlife is associated with a longer life expectancy. The very thing we fear is a thing that is keeping us alive and thriving and powerful. Next slide. I just want to leave you with one anecdote before you jump in, Wendy. Is that in the talk that I did at IADEP back in 2016, there is a story that I absolutely love. One of Margot's clients talked about the fact that she was beginning to make peace with her spare tire, as she called it. But she said, I am coming to recognize that this is not just a spare tire, it's my life preserver. And it is what's going to help carry me through and help me survive and thrive beyond middle age.
Yeah. That's such a great way to think about it, that my spare tire is actually my life preserver. I love that. Thank you so much. You guys, thank you all for being here. We have 118 people on, and we so appreciate the time you're giving for us to all be together this evening. I'm Wendy Oliver Pyatt, and I'm the co-founder of Within Health. And thank you for allowing me the chance to speak tonight. I'm going to kind of go through a lot in a short period of time. And if we don't get through everything, or if there's more additional follow-up that's needed, Erin will help be sure that we connect. What I'm going to do is kind of go through, because my good old-fashioned way of doing psychiatry is a biopsychosocial approach. So you're going to see that I kind of have a biopsychosocial order of the slides, which makes sense to me. I hope it makes sense to you. And then in the end, some special topics. So I'm going to jam through these slides, and I hope to give you some tips and some ideas of like how to actually work with this. So menopause occurs in 3 stages. Perimenopause actually can begin as early as age 30 into a person's 40s. Menopause actually is when you've had no menses for a year and your ovaries are no longer releasing eggs. I must admit, when I finally reached menopause, I was in denial. I was like, what? That's not me. And then postmenopause is everything after that, i.e. the rest of your life. And most women actually go through menopause between 45 to 54 years old. Average age is 51. But here's the trick. Here's the clincher for us. Our life expectancy is really going way beyond what probably we were like kind of planned for by evolution. So we really are in this conundrum of figuring how to have the best possible quality of life as we age much past menopause, but not drive ourselves crazy. So that's one of the main things, a theme that you're going to hear me talk about is like things that we actually can do that are productive for menopause, but being aware of when that tips into disordered eating and eating disorders. So menopause, as mentioned earlier, we've talked about all this, the sleep disturbance, cognitive, memory, mood, hot flashes, sexual dysfunction, and vaginal dryness are some of the main manifestations. So again, going to the biopsychosocial model of this. So on a biological level, you've got, and this is way overly simplified, but in a biological schema, you've got the hormonal changes, and then you may have also exacerbation of pre-existing other conditions as well, including eating disorders, by the way. The person had pre-existing eating disorder. Then the psychological piece is, we talked a little bit about gaining mastery of your body in the face of changes outside of control. And one of the things I want to always mention whenever I hear the C word for control, I like to, because the word control sometimes has a negative connotation, like, oh, she or he's trying to be in control. And I always try to reframe our staff, instead of using the word control, like to remember the person's trying to feel safe. The person seeking control is actually seeking to feel safe, just something to think about. So also there's a defiance of mortality that we all, to some extent, live every single day with some defiance of mortality, but it's about the continuum. It's about going to the extreme with that. And then, as mentioned, the concept of staying relevant and coping with loss. And then also replacing external targets. I mean, when my kids were home, my kids were like, kids, career, you know. So you have this thing outside of yourself to focus on, and then maybe you're towards the end of your career. You've decided to retire because you're tired of working so much. I mean, when I took a little hiatus from work, I thought I was just gonna like go to the beach and do yoga and walk my dog. And like, I literally just kind of lost for a while. I was like, oh, I don't know what to do. I was just sort of truly unwinding. But I looked back on it, I was like, I think it was like 9 months of like really just like not knowing what I was doing every day and feeling a little bit discombobulated. But I can see how in that setting with other variables, you could be like, well, I don't know what I'm doing. I might as well get fit, you know? And so again, it's all about staying in balance or not staying in balance. The other thing on the social piece of this is a lot of the things that are going on that are stressors, that are really extreme stressors, are normalized. For example, divorce is very common, but it's seen not as a trauma because, again, it's so common. It is very traumatic. Or the empty nest syndrome is seen as like kind of said in passing, kind of funny. Oh, you're having empty nest syndrome, but the person could be really, really troubled by that experience and really be suffering and in a great deal of pain. So, you know, oh, you're single again. Oh, you're going to go out and date. And when in reality, you know, those of us who've been through something like that, like the idea of going out and dating sounds like absolutely horrible. So coping with loss, and sometimes that's minimized. And in addition to that, because we are more mature, we're thought of in a sense of sort of, we should have our act together more. We should really be more put together. I remember one person said, well, you're older and wiser now. I'm like, I feel more vulnerable now. I don't feel wiser. I feel more shaky. One of my friends just told me this the other day. She's having some marital trouble. And she goes, I used to be so confident. And I would just say, knock it off. And now she feels more shaky. She feels more vulnerable. So that vulnerability is also going on. So biopsychosocial is really a good way to formulate, I think, understanding what's going on. And so women with menopause and mood, women are 2 to 4 times more likely to experience a major depressive disorder during menopause than any other time in their life. So all of these life changes are also changes in hormone. And then, as we talked about, the other psychosocial issues that are going on. So we can keep going. So menopause may precipitate a psychiatric disorder in women who may be predisposed. Catch me on another talk to talk about intergenerational trauma and epigenetics. So there's predisposition things that can be going on. And then there's also this concept of personal myths and expectations related to menopause that are highly likely to affect the way in which women cope with it. And that's one of the things that I want to talk a little bit about, is how different cultures are when it comes to menopause. In fact, one of the things I was doing in preparing for this talk, I had always wanted to do more research on those cultures that are matriarchal, where like the women are the bosses and the women own the property and all that stuff. So I did a little research on that, and I had a big long slide about all that. And I realized, okay, you're getting a little off topic, just make the point, but it was very, very interesting. But our education, culture, and life events weigh heavily on the impact of menopause. But I really think culture is a big part of it. Our culture is a little wacky in this area. And then I am a psychiatrist. I'm not a gynecologist. So everything I'm saying, I'm going to talk a little bit about hormones and stuff, but this is all under the umbrella of like, seek your own treatment in that area. I'm just sharing experiences and the fund of knowledge that I have, but I'm not a gynecologist. So everything under that umbrella is just kind of like for your information type of thing. One of the things that I think is really interesting, though, to consider when we're considering midlife eating disorder presentations, that there really could be often, I think, are underlying psychiatric diagnoses that present as the eating disorder. And what happens in treatment, a lot of times people start to chase the eating disorder symptoms, like chase. But when in fact, there's an underlying psychiatric thing that was exacerbated due to the loss, that, and also CPTSD, chronic post-traumatic stress disorder, is something very real and is now in the ICD-11, by the way. So we're beginning to understand trauma in more than one way, and of course the treatment in more than one way. But I've, over the years, really begun to see that the primary psychiatric condition expresses itself in an eating disorder. So you can see in restricting anorexia, the avoidance that you see in trauma, well, like restriction of affect, apathy, you know, the I find, disconnection from food, disconnection from appetite and hunger is kind of akin to a disconnection from the source of life, which is food. And that's that an avoidance or that sense of foreshortened future that you can see, you know, in trauma. Arousal, you know, I call it the faulty alarm system. So arousal and trauma is the exaggerated startle response, the excess like hypervigilance, the outbursts, and an eating disorder is that faulty alarm, like no alarm when you're starving, no alarm when you're, purging, but red alert if you ate, a bagel type of thing. So the faulty arousal, and then the reliving piece that I've seen time and time again, when you treat the eating disorder holistically, you kind of can find the actual psychiatric, the trauma underneath it. And so the way the food just takes everything up in the person's mind, it makes it harder to kind of find what the underlying trauma may be. And now what's really great, and nowadays, as opposed to when I first was doing that, as a trauma is now understood to be a really important part. 80% of people that go to residential have co-occurring trauma. We used to be told by insurance payers that you're not allowed to treat trauma and you're in residential, by the way. So yeah, for those of us who've been around, we used to tell our clinicians, don't tell them we're treating the trauma. All right, keep going. Sorry, Erin. And so the manifestation of depression, if you think about a depressive symptom, and then you can think about in the midlife, the way that kind of expresses itself. So unintentional weight loss or weight gain and a decrease or change in appetite, that's a part of depression, is acted out in the form of the relationship with food, or just losing pleasure and pleasurable things of life, where the interest is just all about food, eating, cooking, restriction, calorie counting, one of the things just because I'm going kind of fast, the impaired ability to concentrate or make decisions or limited perspective really gets translated in the self-perception, body dysmorphia, the hopelessness of that, and the distorted perspective. I think that of anything that you see in depression and also in eating disorders is that distortion of perspective of like what really matters. And that's why ACT and value-based treatment is so important. And I like to think of eating disorders also in any stage, but also midlife. We want to be thinking when we're working therapeutically with patients, what are the defenses that are going on? Well, we all have defenses going on all the time: denial, avoidance, sublimation. It's a part of life, having these defenses. And for our patients, sometimes these defenses are sort of out of control. So I just wanted to kind of help us think about that as a normal thing. And the brain is really operating from memory and wants to avoid danger. Our brain's number one job is like, don't get into danger. And abandonment and being alone is a big time danger. So like, if you just distill down our behavior, if you really talk to somebody about why they're restricting, on some level, there's a part of them is like, this is tied in with attachment and a fear about isolation. So you can keep going. So I'm just going to kind of go through some of the defenses that are at play. We all know that these are unconscious strategies that we're trying to protect ourselves. They're not necessarily bad. We all have them to some extent. And again, I thought this was just such a lovely quote. The brain operates from memories and wants to avoid danger. We may occasionally respond quickly, defensively, and even thoughtlessly. So defenses to consider, like, that just refusing to recognize that, real things are happening in life, such as aging and mortality. So reaction against that whole process of aging. We're all aging all the time. So it's just kind of one of those things. But if it gets out of balance, that not ability to cope with that, you might see unhealthy coping. Just repression, blocking things out that are really mattering, and then being on top of the food, the weight control, the running, the calorie counting, etc. Just regression is another thing that we can see as we age. Like I was saying, I feel more vulnerable. I don't feel stronger. I feel more vulnerable. So we might be more likely to regress back to prior coping mechanisms. And if it was an eating disorder, maybe that can happen. Displacement, you can take the anger, the sadness, the grief out on other people, but also on your body. Can keep going. Reaction formation is we just do the total opposite, so we might feel weaker and more vulnerable. So we're in the gym and we're pumping, we're pumping and we're lifting, and it's sort of helping us kind of overcome that issue. Sublimation is a very healthy, in general, a defense mechanism, and it can be a productive adaptation. But a lot of times, if you have unacceptable urges, you can channel them into something, productive. Like a football player might really want to be aggressive, but you could just like go tackle somebody instead and then get a college scholarship. So that works out okay in that situation. Intellectualization, I think you see a lot of this in like the orthorexia nervosa picture, just just instead of any sort of heart to things, it's just, all the details about the food and the science. And those patients are really, really hard to treat. We see a lot of orthorexia, and we also see atypical anorexia nervosa in mature women, which is a whole nother conversation, atypical anorexia nervosa in mature women. Compartmentalization. I mean, that's a good one. I'm compartmentalizing right now. I'm like, my dog is in the other room. My dad is over here. My dog isn't going to bark. Hopefully my Wi-Fi won't go out. So compartmentalization is really great, but it's like sometimes people are just compartmentalizing too much and they're just in the gym, and this just kind of takes off like wildfire. You can keep going, Erin. Sorry if I'm going so fast. I'm just trying to get through a lot of slides. Hope it's okay. So I always like to talk about needs because Kaufman, I think, is an under-recognized analyst that talks about the interpersonal needs. So as we think about any eating disorder, we're thinking about the eating disorder is a way that person's trying to get their needs met. We're all trying to get every day, we're just all trying to get our needs met. Like that's what we're doing. And people with eating disorders are trying to get their needs met. So it makes a lot of sense to kind of like figure out, okay, what are the needs that we have? Well, there's a need to feel loved and wanted. In midlife, you can feel really replaceable, left, just unimportant. So identification is that we have a need to feel like we're sort of a part of a personal culture of something else. And so in adults, the loss of a culture of being a parent, for example, that was a big one for me. Like, wait a minute, I'm not going to school every day. And when my daughter didn't forget her homework and I don't have to go to this and I don't have to do that. And I'm like, wow, I think somebody mentioned the free time, the need to nurture. We want to both give and receive love. And in reality, like the things that we physically hold a lot of times aren't around. Like one of the things I hold is in New York. One of the things I hold is, in different cities. They're not here anymore. The things I hold. Well, I do have a dog and 2 dogs and a cat now to help me with that. So touching and holding as described. Differentiation is also a really important need, and sort of becoming our own individual creature that's separate from being all these other things we were to all these other people. The other big one that I noticed in my life was I had a lot of friends that were tied to me through shared parenting. So my friend Charlene, her kids, my kids, we did a lot of things together as parents of kids the same age. And I find it really difficult to not have that in my life. And then affirmation and the need to feel valued. And older women, especially in Western culture, there is still that thought of like the old maid syndrome. You can keep going there. So in Western culture, menopause is fertility failure, ovarian failure. In Mayan culture, women are respected as elderly and status raises. In Chinese culture, it's a rebirth. Younger women are relegated to the childcare and the older women are more elevated. And interestingly enough, in Iranian culture, menopause is a natural happening and it's associated with more freedom to have sexual relationships because you're not allowed to have sexual relationships when you're during menstruation. So this part of the whole talk where I was looking into this, I was just like, I could just talk about this all day, the different cultures. It was very interesting. All right, we can keep going. I want to touch on really quickly osteoporosis. This is a very important thing to talk about for people. Again, not my area of expertise, but it's a really important thing because especially if our patients have already had an eating disorder at adolescence and are at risk for osteopenia and osteoporosis, then they hit menopause, and then if they have an exacerbation of an eating disorders, that is a very, very, very big problem. So 1 in 2 women in menopause experience a bone fracture related to osteoporosis, which is absolutely crazy. So I call it triple jeopardy: eating disorder in youth, menopause, and now a new eating disorder. That's a lot to come up against. Next slide. The Women's Health Initiative was from 1991 to 2001 done by the Fred Hutchinson Cancer Research Center, of a study of 160,000 women of risks of cardiovascular and cancer risk. And what ended up happening out of that is a lot of information got put out about the use of estrogen, and a lot of assumptions were made about it. A lot of doctors are like, oh, hell no, I'm not giving hormone replacement therapy. the thing to understand, the take home point is that the estrogen that was used in the Women's Health Initiative was Premarin, which is a conjugated equine estrogen from pregnant horses. It's called Premarin because it's pre-mare urine. That's why it's called Premarin. It's a synthetic estrogen, and it's not the same as bioidentical hormones in a nutshell. So that's important to know. Talk with your doctor about it, because it's possible that some of us may benefit, in my opinion, from bioidentical hormones. That's my opinion. But again, I'm a psychiatrist. But I have done a lot of work on this, and this is some opinions that I have that I'm sharing for better or for the worse, because if you do have these risk factors and you're having cognitive, mood, anxiety, osteoporosis risk, and somebody just says, well, you can't take hormone replacement, I just encourage you to dig a little deeper. I won't read this whole slide right now, but there's been plenty of critique of the Women's Health Initiative. I'll just leave it at that. You can keep going, Erin. So bioidentical progesterone has not really been felt to have the negative effect on blood lipids or vasculature as the synthetic, and does actually suggest reduced risks of blood clots compared to non-bioidentical preparations. And bioidentical do have effectiveness in addressing menopausal symptoms. And you can see from the NIH where I got that data from. You can keep going. So the benefits of bioidentical hormones, which again, I think are very relevant for some of our patients going through midlife with psychiatric conditions and eating disorders, is the estrogen can address some of these things that we've been talking about. A big one is progesterone. Progesterone is really tied into anxiety and insomnia. So I think that out of the things I use with my patients, progesterone is really it works really fast too. It's like they start taking, obviously you have to get assessed, but I'm saying if there is a problem there, it makes a really big difference. Another one that doesn't get talked about is pregnenolone, which is really, it actually supports many neuropsychiatric conditions and is getting some research even around helping in prodromal schizophrenia and other mood disorders. It also has some research in pain modulation, and it's actually it actually helps with neurogenesis, and it also can help with that kind of calming effect from progesterone. And then testosterone drops off too, and that can be affecting libido, mood, vaginal dryness, concentration, and muscle mass. You can keep going. Steps to recover, I kind of just broke it down. Find a program that meets the needs of mature women. I'm going to sound like an advertisement for 10 seconds, but at Within Health, it's been really amazing because we have a lot of these mature women from all over the country doing things together. We have a breakfast club where they eat together and they're forming community. And it's like a lot of them are women that have had bad treatment experiences. And so they have treatment trauma, or they have reasons they can't just go to treatment, and they have these groups. It's just so powerful. The Breakfast Club has been really amazing. So I mentioned being aware of baggage from prior treatment, because treatment trauma is real, and I always say affirmatively declare a war on diet culture, declare a commitment on gentle self-care. Remember, we're role model for future generations. And then radical acceptance of the circle of life, very much easier said than done. Finding meaning in aging, becoming an activist. And there's plenty of things to be an activist about these days. Dream, get the dog, take the trip. One of my friends is going to South Africa right now. I went ahead and got my cat Saber. You can follow him on Instagram, Saber the Magnificent. I'm obsessed with him. He makes me happy.
That is a plug. That's a plug right there.
Yes, Saber the Magnificent.
It's a hell of a cat.
Dream, he is a hell of a cat. I should just show him right now. Reconnecting with spirituality, music, dance, art. I mean, just go for it. As I say, shake what your mama gave you. We just got to support each other. Oh, thank you, Kath. She said Saber was so precious. I saw that in the chat. But shake what your mama gave you. Let's be bold. Let's pretend like we're not from Western culture. Let's be queens. Let's support each other. Let's be badasses. Let's be opinionated. Let's take up space. Let's hold each other. Let's have fun. I said to Bits, are you going to dance at the end of this? We got to take that leap and really hold each other and just really fight the oppression, fight that successful bull crap. Okay, next slide. So I kind of think the key to navigation of menopause, in my view, is to strike that balance between remediation of symptoms cause my menopause, that can cause true biopsychosocial impairment. Again, we're living a lot longer past menopause. I hope I am. But strike that balance with acceptance of aging and aging with grace. And oh my God, I love this. I love this quote. I stumbled across this quote a while back, Eric Fromm. So this is really interesting because it really makes me think about aging and mortality and what we're all really afraid of, which is being alone and death, things like that. At the end of the day, it's very existential anxiety as we face as we're aging. So the task we must set for ourselves is not to feel secure. Like we're always trying to feel secure. It's actually not to feel secure, but to be able to tolerate insecurity. And that's kind of what we're doing. We're tolerating insecurity. How do we do that? We do that together. Guys, thank you so much for being here. And we made it through most of the slides. I am free to stay on for a little bit if anybody wants to have a Q&A, but if you need to go, that's cool as well.
Yeah, thank you all so much. That was amazing. The comments are just like, thank you, want to hear more. So they're just so grateful for your time. And we will stay on for a few minutes for questions. But again, if anyone has to hop off, no problem at all. This will be recorded. It has been, and it will be put on our website and sent out to you all in the next few days. So one question and some curiosity was around, are you seeing the majority of eating disorders in midlife are new onset eating disorders, or oftentimes a relapse or something that individuals have been struggling with for most of their lives?
I'm seeing more of the person that's had an eating disorder for a long time. I've seen a lot of people that have had not necessarily the best experiences in treatment. I've treated women who were in their 50s, who went to treatment in their 20s when care was very hospital-based, and they were, restrained, put on, Haldol, and really bad treatment experiences that didn't really understand that treatment is different now and can be very different. So that's what I'm seeing mainly. Any comments from the other people?
I think the data shows that it's more of those individuals who may have cycled in and out of severity, different kinds of behaviors in a kind of subclinical way, and have maybe what they term to be better than they were when they were younger, but it still is a serious situation. And I think there was another question too, because we didn't talk about binge eating disorder. I'm sorry, Leslie.
I was just going to jump in on what we're seeing. I think one of the rewarding things now is being more in general primary care at a referral-based tertiary care center. Is I'm seeing a lot of people who've never been diagnosed with an eating disorder before. So they're middle aged. No one has ever brought it up to them. It has always been this very weight-focused approach to how they've been managed, congratulating them for any losses, chastising for any gains. And so I am oftentimes the first person who has kind of brought the whole picture together and presented them like, this is problematic and let's look at how we can address that. So I definitely, just because of the environment that I'm in, I'm seeing a lot of people, or people who have had like these $1 zillion medical workups at the Mayo Clinic, who now for the first time, someone is saying, hey, can we have a fresh set of eyes look at this, because we think there's something else going on. And I'm the first one kind of presenting it that as an eating disorder.
And I think there's also tremendous shame on the part of those who may suffer from binge eating disorder, because they've received very negative messaging over time, and they may have cycled in and out of varying kinds of behaviors over years as well, and find themselves at this point in time, really getting a lot of judgment on the part of family, friends, and medical professionals, where the focus is not health, but size and shape. And that is devastating for those who feel like they're trying to get a handle on all of this, and the totality of what they're experiencing is not addressed.
And
I
I,
just
I,
wanted
def- oh, go ahead.
We have so much to say.
Great.
I just wanted to make sure that Deborah Benfield's question
Yes.
brought up, that I absolutely agree around the binge eating disorder. And if in my rush or haste, I neglected to make that clear, I'm very interested and care very much about that population. I think that a lot of binge eating disorder is actually atypical anorexia nervosa, and that the restriction that we're seeing oftentimes goes into binge eating. So I just really didn't get enough time to talk about that, but I think that was a really important question. I want to make sure I got to kind of respond to Deborah's comment there. Thank you very much.
And I think one thing that I've noticed too is, again, being at a larger medical centers, oftentimes people don't really understand eating disorders, and they'll have patients that have quote unquote struggled with their weight will be referred to me, I think, because they don't know what to do with them. And it's so freeing oftentimes when I have an opportunity to sit down. I just had a woman recently in her 60s, and we were able to sit down and I diagnosed her with binge eating disorder. And we were able to kind of talk about how that has played out in her life. And I think there was a sense of freedom in that, of being able to take it from a different approach and not having this constant battle, if you will, that she'd been having with between herself and her body and her medical professionals for years, trying to get it to conform, if you will, to a certain standard. So it's very rewarding.
It's awesome.
I mean, I think that leads to another question that was brought up around how can we manage health issues as we age, higher cholesterol, blood pressure, all these things, when the majority of providers recommend diets or disordered advice that just trigger the eating disorder. So just, you are not in every city, unfortunately. So most people are not.
You really have to be prepared when you go to the doctor, because, and it's sad because most people don't. And we were talking about like chasing symptoms, where, it's not really about focusing on, it's not focusing on like weight loss. It's focusing on self-care. It's not focusing on cholesterol. It's focusing on gentleness and the underlying dynamics of self-care that need to be addressed. And it's like that Einstein quote that says, like, you can only solve a problem by approaching it at a deeper level than it presents. And there is nothing more true than this when it comes to health. And unfortunately, Western medicine is literally blind to this. And it's why we have a really sick, mentally unhealthy culture. By the way, we have a new number coming out, and our 988 is going to be the number for the suicide prevention, which I'm glad we have it, but it's sad and scary that is needed in our society. And eating disorders, I forgot to say, but that eating disorders are associated with a higher risk of suicidal ideation, suicide attempts. I mean, if you have all this loss going on, you have hormonal changes, maybe you have a pre-existing other psychiatric condition, and now you're very conflicted about your body and eating, you've gained weight and you're, catastrophizing, over that. And it puts a person into a state of extreme despondency.
Yeah.
I will say that the question about how to respond, it is an uphill battle in terms of dealing with medical professionals. I mean, those are my colleagues. I deal with that day to day. And I really think it requires a certain level of self-advocacy when you go in to see your provider, unfortunately, and just really requesting that we discuss my health independent of my weight, because there are so many other objective things that we can monitor other than weight. And I think it's become a really lazy tool that providers use to kind of broad stroke say you're healthy, you're not, you're good, you're bad. And it's quite frustrating. And I think COVID has really exacerbated that. The entire world has just gone through a very, very traumatic event, which turned our lives upside down. And not surprisingly, as a result, a lot of our regular routines were disrupted. And so, of course, people are potentially going to gain weight when you're stuck in the house for long periods of time. And I've had so many people that are fearful to even go see their doctor because they're afraid they're going to be chastised because they gained 15 pounds because they were locked in the house, scared for their lives for 2 years. So I think that what I talk to patients about is you're a survivor, like you've just come through, we've all come through this very traumatic event together. And if the only thing that you have to show for it is 20 pounds, you should be happy and embrace that and move forward, because, this has been life altering. And for us as a medical community in general and a society at large to be so singularly focused on something that really is not a direct reflection of our overall health is something that we all should be striving to move past. So I just encourage you to really seek out providers that will kind of meet you where you are, and really kind of take more of that weight neutral approach to your overall health and really look at it from a more holistic perspective.
Absolutely.
Absolutely. Hey, I wanted to mention to Karen, thank you so much for your comment about being treated as a teen and a 20-year-old in groups.
Yeah.
That is one of the definite things that I think that I've seen, as a person developed programs. And one of the things that we did in my other center was we created like separate programming and separate groups, sort of safe space. And that's one of the things I think that is important, it's hard to find, but that's a value that I have. And it's something I'm really happy about within that we have these congregation of folks that are a little bit, in the 35 plus group that are finding a lot of camaraderie in the healing process.
And I think there's so many different elements towards, the fear of, and legitimately so, the fear of going into a program where you might be the oldest person in the milieu.
Mm-hmm.
And that, as I said earlier, the successes that you had are, you're kind of lumped in with the rest of the clients who may be younger and have very different issues. This is a population that, may have had a successful, not successful, maybe successful career, taking care of, maybe have raised children, maybe takes care of older parents, and a host of other strengths and insights. And it's learning how to really address the function of how that eating disorder lives and breathes in that individual, as opposed to looking at them as that kind of barcode client.
The other thing that happens a bit too, and I'm going to be really honest here, sometimes people who come in that are older, they feel like, and I can imagine, they feel like because they're older, like they shouldn't have the same kind of containment or boundaries. And it's very confusing because they've been running the household or running a business. And now you have like a care partner telling them, what time they can, whether not flush the toilet or something like that.
Right. I think that's very difficult for those who've never been in treatment, or those who are for those who've never been in treatment and those are returning, is the sense of that kind of loss of that sort of adult identity. That's the best I can describe it. And, for a treatment program, understanding that that's not someone necessarily being difficult. I've advocated for many individuals contemplating going into treatment at more mature ages. And, they're, as I would be, really, they don't want to share a room with someone who's younger than they are. They're sort of privacy issues and sort of some embarrassment about some of the way that their body functions, or the way that they don't sleep. And so often I think that is a bit misunderstood. And I think too, to your point, Wendy, sometimes those individuals don't often recognize where their own personal development may have stopped along the way as well, as a result of the eating disorder.
Yeah. And that's very tricky. And it really requires a deep connection with that other human being who's giving up so much by being in treatment in one way, shape, or form. Because for the person to go from being the CEO of their life, the CEO of their home, running their whatever, to being, in that vulnerable position. Mm-hmm. If you don't have a deep connection with that other, as a provider of that person receiving your services, if you're not able to engage that person in a deeply meaningful way, it's just all it is then is abrasive to the other person. There's nothing in it that feels substantial and a reason to hang on. So that's where we have to be really, I think, disciplined about how we deliver care. And we're really focusing on the quality of the therapeutic relationship as the foundation to everything.
Yeah.
I think that one thing I've noticed too with this life stage and encouraging people to get help is that they're finally at that time where they can take a breath, right? Like I've
Right.
spent my entire adult life kind of raising my kids and taking care of my family and working on my career. And finally, I have this moment. And even if it started with this idea of feeling somewhat lost and what's next, but then it's this opportunity to look within and say, like, I want this next phase of my life to be about me and really have that opportunity to say, you know what, everyone else is settled. They're in their place. I've spent all my energy and focus on them. And now it's an opportunity for me to really turn inward and really kind of accomplish these goals that I had for myself on a personal level and get the help that I've needed for so long and neglected. And so that's also another exciting time. And then oftentimes they have not only the time resources, but sometimes that financial resources to be able to do some of the things that they couldn't earlier. And so it can be freeing for women who are looking for that, what to do in their next stage. It's this opportunity to heal yourself of something that has maybe been, kept you captive for a really long time.
I also think sometimes there is fear other than just being in a milieu where you feel a little like a square peg in a round hole. I think there are sometimes for those that have been at this for perhaps decades, perhaps since their early teen years, and they've been cycling in and out. And I think there's some real fear and worry about what that level of treatment may uncover, and having to really confront the fact that they may have been at this for a long time and the damage that it has done, both physically and emotionally, to every aspect of their lives. And as I often say to individuals and their families, this disease, in whatever form it takes, is a destroyer of worlds. It can destroy everything in its path. And I think that there's some fear about uncovering and really confronting the length of the disease and the possible damage that it's caused. And I think there's a tremendous amount of worry about confronting that as well, and having to face that boldly, which may be a very difficult thing to do.
Well, I just want to say questions keep piling in, but I really want to be aware
We
of
need another hour.
time. We do need it. Maybe we will have to organize it too, but I want to say just on behalf of all our participants that Within Health is an amazing organization. And if anyone on this call is considering treatment in older age, please check them out, because being virtual, it just changes everything. And they're doing it right. So you have Erin's number and their contact information. And if you're interested in EDF support groups, you can go on to our website. All of our services are free. So please, that 50+ group that I was talking about in the beginning, and we'll hopefully be adding more programming for individuals 50 and older. So please keep an eye out for all of that. But
is your 50 and older just for people in Colorado?
No, it's virtual.
Okay.
So
That's awesome.
That's good to know.
Yeah.
Awesome.
Yeah.
That's so fantastic.
It's an amazing, amazing space. So I really want to encourage anyone to check that out. Once you just sign up for our services, you'll get a Zoom link and you can hop on to any support group. So it's really, really easy to access. But
can I say one thing really fast? Because somebody just brought up that having an eating disorder for 50 years. I just want to say that all things are possible and good treatment is available. And if you had it 10, 20, 30, 40, 50 years old, there is a way through it. Yeah. And I just want to say that to the person who put that in the chat. And thank you for being brave to put that out there.
Yeah. Just thank you for being brave, for being on this call and for participating
and showing up.
Having this conversation. We'll download the chat, and so I will share the questions that we didn't really get to with Erin and our presenters, and hopefully put an email together to everyone. But again, please reach out to us individually. We're here to support you all. And to our presenters, thank you so much.
Thank you for having us.
Thank you so much. Oh my gosh.
Thank
All
you
right.
all, and we'll be
Erin,
in
Iped,
touch.
Danny, until next time.
Yeah,
Till next
hopefully.
time.
Until next time.
Everybody
Something else on
join.
the books.
So
Okay.
wonderful.
Oh,
Thank
look, there's
you.
everybody.
Oh my gosh.
Hi, everybody. Oh, thank you for letting us see everybody.
Oh, this is amazing.